Good evening, everyone. We welcome you to this Up to Dates with Updates, episode 3, which has been organized by ISAR Haryana. This is a webinar where we are having a journal club sort of a meeting here. So we have Dr. Jyoti Malik with us. She's the chairperson, Haryana chapter of ISAR.
Thank you so much. Thank you, Dr. Deepika, and thank you, Jackson Paul, on this up-to-date with updates with the blessings of our national president, ISAR, Dr. Ameet Patki, sir, and secretary, Dr. Asha Baxi, ma'am. With their constant support, blessings, and guidance, we are constantly paving our paths to better understanding of things in infertility, and we are constantly doing many such webinars and journal clubs now. So, and we try to discuss the latest topics, both pertaining to the clinicians as well as to the embryologists. And we have our think tanks of ISAR. We have Dr. Ameet Patki, sir. Then we have Dr. Nandita Palshetkar, the immediate past president. We have President-elect Dr. Sunita Tandulwadkar, ma'am. We have Vice President Dr. Madhuri, Patil, Vice President Dr. Sujata Kar, Secretary Dr. Asha Baxi, and the Chairman for Embryology, Dr. Charudutt Joshi, sir, and the Vice Chairman for Embryology, Dr. Keshav Malhotra. So we have these think tanks of ISAR for the up-to-dates, and every time one of the think tanks comes and assesses and sort of assists us and help us to understand that particular article which we have chosen. So not only this, we also have the ISAR Brigade from the National ISAR. We always try to keep 1 or 2 young ISAR Brigade for these journal clubs. And this time we have the 2 embryologists. We have one embryologist from Haryana ISAR, Dr. Shilpa Marwah, who would be presenting the first article, and then we have the second article would be presented by the by Dr. Aanantha Lakshmi, from the ISAR Brigade. So with the team ISAR Haryana, with Secretary Dr. Meenu Handa, the Clinical Secretary Dr. Manju Dagar, and Treasurer Dr. Lakshmi Goyal with me, we bring to you this episode. And for this, it is amazing to have Dr. Charudutt Joshi today with us. Dr. Charudutt is a postgraduate in life sciences, doctorate in life sciences, trained in ART and allied procedures from Belgium, Singapore, Germany, has served as an office bearer for various societies like ISAR, IFS, ACE, ISSRF, and ISPAT. He has been the vice president of ACE, the Academy of Clinical Embryologists, the past president of ACE in 2014 to 16, and he is the medical director of the Genes India ART Bank in Indore. Dr. Charu is the lab director of the RD Gadi Medical College, Ujjain, and he is presently the chairperson of Embryology National ISAR till 26. So thank you so much, sir, for taking out time and for being here as the ISAR think tank today. And our first presenter is Dr. Shilpa Marwah. She is PhD Clinical Embryology. She has a number of she has mastered ICSI, PIEZO, oocyte and embryo vitrification, thawing. She is elected vice chair of the Haryana chapter of ISAR in the embryology. She has bagged second position in paper presentation on the DNA fragmentation, has contributed in a book, Practical Management of Infertility by JP, and has contributed in various chapters. She is an embryologist to many centers in Gurugram, Grace Fertility, Neelkant IVF, Rainbow IVF, Morpheus, Singapore, and she was also in Rainbow IVF Agra in the year 2014 to 2016. She is PhD, MTech, and over to Dr. Shilpa for her first article. And we would be, I think half an hour would be sufficient for discussing this, so that within an hour we finish the 2 articles. The first article is to ICSI or not to ICSI until proven otherwise. less is more in the IVF lab. So over to you, Dr. Shilpa, and thank you. So many participants who have joined us today so that we can learn this latest, we can think whether to ICSI or not to ICSI, or and to ICSI in all, or only in special cases. So over to Dr. Shilpa for her detailed discussion on the topic.
Thank you, Dr. Jyoti, and a very good evening to all the participants and all of the one joining here. Topic, the paper which we are going to discuss today is ICSI or not to ICSI. So until proven otherwise, less is more in the IVF laboratory. So the paper is presented by Calais Hunkler and Russell P. Hayden and Kate Devine. So journal is Fertility Sterility, and this paper is of May 2024. So the purpose of study is to evaluate the necessity and impact of ICSI in the absence of male factor infertility. So is the ICSI is a necessity in absence of male factor infertility, or IVF is sufficient to go for the people with absence of male factor infertility? So what they say is IVF add-ons such as ICSI are under scrutiny. So these technologies are widely being adopted as a justification without solid justification. So we are widely using ICSI without proper solid justification. It's just an add-on and we are using widely. So the main concern of this paper is they say we are overutilizing ICSI in non-male factor infertility cases. So the potential negative implication of cost effectiveness and outcome is still not known. So we are overutilizing ICSI where it is not required. It is still a debatable topic. It is still controversial, and we don't know the long-term outcomes of ICSI in case of pregnancy, neonatal, and pediatric outcomes. If we talk about ICSI and PGTA, so we all know ICSI is intracytoplasmic sperm injection. The procedure is a single sperm injected directly into the egg, and we ensure the fertilization when sperm quality is poor. PGTA is pre-implantation genetic testing for aneuploidy. So we test embryos from chromosomal abnormalities before transfer, and thus increase the implantation rates and reduce the miscarriage rate by selecting single euploid embryo. The hypothesis is ICSI could prevent genetic contamination, thus improving PGTA accuracy. So if we do ICSI before PGTA, so that definitely helps prevent genetic contamination because we have a certain sperm stick after IVF, and that may leads to a contamination, and thus a false result of unfertilized sperms may occur. But still we have lack of robust evidence data supporting this hypothesis. Increasing use of ICSI. So rising use of ICSI with PGTA cycles despite limited supporting evidence. We don't have evidence so much supports that says that yes, we have to do ICSI before PGTA. We can also do IVF, but still we have a fear of genetic contamination from non-fertilizing sperms. So current evidence is high quality studies do not confirm improved PGTA accuracy with ICSI. There are no studies that confirms that yes, ICSI with PGTA have higher accuracy than IVF with PGTA. Now, main concerns of ICSI are potential for adverse effects on pregnancy and neonatal outcomes. We don't have much data, and yes, there are some studies that says ICSI has possible long-term pediatric health implications, and yes, ICSI has long-term effects on pregnancy and neonatal outcomes, but still it is a debatable topic. Still, we don't have much data to prove this, that yes, ICSI has long-term effects on pregnancy and neonatal, and still it's a controversial topic, and more of research needs to be done to confirm this. Now, the key question is, do the risk of ICSI overweigh its perceived benefits in non-male factor infertility? Do really ICSI has certain benefits that we can avoid doing IVF over ICSI in non-male factor infertility cases? Do really there's a need of doing ICSI where it is non-male factor? So now what study says? Study objective is to determine if ICSI offers significant benefits over conventional IVF for non-male factor infertility cases. So do we have certain data that says yes, ICSI has certain benefits over IVF? And this is a retrospective cohort study, and the data source is Society of Assisted Reproductive Technology Clinical Outcome Reporting System. So the time frame they have done for this study is 2014 to 2017. Study design. So data collection, so they have collected data over 30,000 IVF cycles, where 4,800 cycles are of IVF and 25,000 cycles are ICSI cycles. So inclusion criteria are cycles without male factor infertility, because obviously in male factor infertility, we go for ICSI cases. We have no option for IVF. And what are the primary outcomes of this paper is, the two studies they have done in this paper is the proportion of embryos suitable for transfer after PGTA and live birth rate per transfer of a single suitable embryo. And they have done a statistical analysis of comparison of outcome between conventional IVF and ICSI groups. So primary outcomes are proportion of PGTA tested embryos suitable for embryo transfer. So embryos suitable for embryo transfer with IVF and with ICSI are almost same. It is 41.6 and 42.5 with ICSI. And the live birth rate per transfer of single suitable embryo. So with ICSI and with IVF, there are not much difference. So with ICSI, with IVF, the live birth rate per transfer of suitable embryo is 50.1 and with ICSI it is 50.8. So there are no significant difference in primary outcomes between conventional IVF and ICSI. Now the key findings, the key results are similar proportion of embryos suitable for transfer in both the groups. So comparable live birth rate per transfer. Now the implication is ICSI does not come for additional benefits over conventional IVF for patients without male infertility. So as per their study, they have not found out any additional benefit of ICSI over IVF in case of non-male factor infertility. So consistent with findings with Owamato et al. In 2022, which also showed no significant difference in outcomes. And there are some previous research are also available from other journals and other researchers. They also say, so Owamato et al. In 2022, they also evaluated the cumulative live birth rate and cost effectiveness. So he also find out that there are similar live birth rate in patient with ICSI versus in conventional IVF. So it is 64.7 in fact in ICSI, and with IVF it is 69%. So it's more in IVF. There are other studies from Deng et al. And Palmerella et al. They also studied impact of fertilization method in mosaicism rates and compared aneuploidy rates between conventional IVF and ICSI. But obviously these data have some limitations. So the limitation is that it does not specify euploid embryos, mosaic, and aneuploid designations. They always say suitable for transfer designation across. They always say it is suitable for transfer, but the word suitable for transfer is definable. It's separate for all institutes. So it's not specification. So they don't specify euploid or what happened in case of mosaic embryos, or what is aneuploidic or what is euploidic. They could not assess the effect of specific PGTA methods on outcome. So what is the effect of PGTA method on outcome? So they have talked about ICSI and IVF, but what is the effect of PGTA? They have certain limitations. The study population does not include male factor patients. Limited ability to evaluate detailed ploidy status and long-term outcomes. We also have certain limitations that there are limited neonatal follow-ups available. There are no data for long-term pediatric outcomes. There are certain studies that coming up that says that yes, ICSI have long-term effect of pediatric outcomes and neonatal outcomes, but we don't have certain defined study that says yes, it affects. Studies are coming up, more data is coming up, but still we need more and more studies to coming up that yes, if ICSI affects the neonatal and pediatric outcomes. still more research needs to be done. So that is why they arise that question that do any benefits of ICSI in PGTA cycles outweighs potential risk to offsprings? That there are certain benefit of why we doing ICSI in PGTA cycles. There are that outweighs also certain potential risk to offsprings. More comprehensive studies needed to evaluate long-term outcomes and benefits of ICSI in PGTA cycles. So high utilization of ICSI, so skewed towards ICSI in US for non-male factor indication. So more and more of embryologists are moving now towards ICSI for all. So this is the question for them also, that is it worth doing ICSI for all, or still we need to move to IVF in case of non-male factor indications? Because when it is male factor indication, definitely we have to go for ICSI. We have no other option left with us. But if there is no male factor indication, is it worth doing ICSI, or IVF is sufficient? Or do we have certain drawbacks of doing ICSI, or do we have certain long-term effects of doing ICSI? So there are some research challenges also available with this paper. Is there are unequal groups or limited statistical power in future studies. So practical implications is efficiencies IVF lab, potential impact on pregnancy and pediatric outcomes. Logical error in ART is we assume that alternative hypothesis ICSI benefits rather than null hypothesis. So if we talk about conclusion, so main takeaway is this: high quality evidence needed before adopting ICSI for PGTA without male factor infertility. So there are certain studies that support previous finding against routine ICSI use for PGTA. So we all are using ICSI before PGTA in order to avoid genetic contamination. So that we all embryologists believe that there are certain sperms that stick after IVF. So in order to avoid that genetic contamination, we always prefer doing ICSI before PGTA. So is it worth that we should do ICSI before PGTA, or IVF is also good? So resist adopting new IVF technologies without rigorous evaluation. And final thought is ICSI should not be used for PGTA cycles in absence of clear male factor infertility indications. So these are the authors, and there are certain references from American Society of Reproductive Medicines and the Society of ART, Fertility and Sterility 2020. And there are certain other articles from Fertility and Sterility that also accept this study and also in favor of this study. Thank you so much.
Thank you, Dr. Shilpa. It was very short but very, very precise. And now I would invite Dr. Charudutt sir for his comments and for the discussion. Charu sir.
Yes, good evening, madam. So this topic is it's there from long time. ICSI or not ICSI, ICSI should be done for every patient or not to do. And there are lots of panel discussions and group discussions and debates already happened on this topic. And ultimately, at the end, we always reach to a conclusion that unless until it is really indicated, one should not do ICSI because it has its own limitation. And there are many studies which has proven. And in fact, this PIEZO-ICSI has been devised for that purpose only. That, from my opinion into this, is that ICSI should not be considered as very casual technique which can be performed by anyone. It needs skill, it needs experience, it needs proper technique in place to perform a proper ICSI. And if it is done properly, then I think whatever PGTA or biopsy or anything what you want to take, you can take it with a good embryo. So that is what is the scene today for me. But as you know, it's always human tendency to find a easy way of doing something. And I feel ICSI for most of us, including me also, it depends on the time management for most of us. So if you have sufficient time, you can go for IVF, you can see it next day, delivered and all. But if you don't have time, then best is ICSI, because then there is no need to touch it for next 5 days. Simply straightway on day 5, day 6, you just take it out, see the quality of the embryo form, blastocyst and all, and you can transfer. So I think, but still, what is your take on Shilpa? I would just like to know about this. Why, if we give 100% ICSI, suppose, so what is the problem with that? I don't think if someone is perfect in doing procedure, so why not? We can always give 100% ICSI. Why we should not do it? What is the limitation of ICSI other than damages or to site or something? Like what is your opinion?
So, sir, according to this paper, they says that ICSI has a long-term effect on pediatric and neonatal outcomes. They don't have much data to say this, but yes, there are certain papers that says that if we do ICSI for all, or if we do ICSI in non-male factor infertility, that may affect the neonatal and pediatric outcomes. So more of research needs to be done to confirm this, and that is why they always says that yes, IVF is preferable because we don't know the long-term effects. So it's a debatable topic.
Yeah, and I think the another important thing which we as an embryologist or as an expert infertility specialist we all misses is the proper semen analysis. I have delivered this talk at so many places, and I always insist one should know proper analysis, properly semen analysis. If properly done, then you have that confidence in the sperms that okay, the fertilization will happen. Because I feel most of the people do ICSI just because to avoid that they feel that it may happen that tomorrow we may not see any fertilization. So at least ICSI guarantee fertilization. But I have experienced almost 5 to 10% cases. Sometimes it also happens that you have less fertilization or no fertilization at all, even doing ICSI also. So, but this is one of the limitation. I feel that we are not giving proper focus on the semen analysis. So probably if we develop better techniques, better confidence in semen analysis, then probably we may find a solution to this. Till then, ICSI is the best choice. We can always have something to offer.
Yes.
Sir,
So,
what are the absolute indications apart from male factor where you would suggest only doing ICSI? I mean, if there are very few oocytes, suppose we've got, would you be just doing ICSI in them, or would you take a chance to do IVF insemination in those those particular cases? What are the cases where would you suggest absolutely ICSI and only ICSI for all, apart from the male factors?
yeah, I feel in my opinion, see, IVF is always preferable if there is no male factor involved. But if we have other indications like previous one IVF pregnancy has not achieved, conception not achieved, embryos were formed. So probably that is one of the place where we can offer 50% IVF, 50% ICSI. In that particular case, still I prefer to go for IVF and give priority to transferring IVF embryos. Second thing is if very less oocytes are there, suppose we have only 2 or 3 oocytes, then better to perform ICSI, because then again it is a matter of chance. If fertilization doesn't happen, then you don't have anything to transfer. But sometimes it also happens that even after doing ICSI, you get fragmented embryos, not very good quality embryos, but at least you have something for transfer to the patient. Then in higher age group patients, it's always preferable to do at least 50% ICSI, because quality of oocyte matters. In higher age group, we all know that zona is thick, the cytoplasm is differently behaving. So probably means doing ICSI in such cases will definitely help, because we don't know tomorrow what is going to happen. And as far as sperm is concerned, most of us see the quality, that is morphology, count, and motility. That's all. But inside of sperm is not practical to taste at that particular time and perform it. And probably ICSI, when we perform ICSI, we try to find out the best possible sperm out of the pool. So fast moving sperm, normal looking sperm. So probably we are offering Means as a human being, we are selecting the best possible sperm out of it and performing ICSI. So these are all the, I think, limitations where we should offer ICSI to the patient. Because this is another important thing is this is an era where patient will always have a question. Whatever you said, I have done and still pregnancy is not achieved. So we don't have answer to it. So probably performing this process quite nicely, quite perfectly will help us in giving some answer to them that, okay, we have done our best.
Right. Thank you, sir. So I think, Dr. Shilpa, small question to you. Do you prefer doing ICSI for all, or how do you do in your practice?
So I think this is a still debatable, controversial topic. But yes, I don't do ICSI for all. I prefer doing IVF also. So yes, what Sir said, it's absolutely fine. We have to assess semen analysis before going for IVF. We have to assess morphology and certain other parameters also. If all parameters are working fine, if we have less number of eggs, especially in poor responders, I prefer doing IVF over ICSI.
Thank you so much. Thank you, Dr. Shilpa. Now we move on to our second article, and where I would invite Dr. B. Aanantha Lakshmi. Yeah, Dr. Lakshmi has certified as a reproductive embryologist from American College of Embryology with the highest score ever in the exam. So that is, wow, that is a big, big congratulations to you, Dr. Lakshmi, for making us proud. And you are the first Indian who's honored as Embryologist of the Month by MCOL. You're ESHRE certified clinical embryologist. You won Budding Embryologist of the Year Award 2024 by Economic Times and won the ISAR Rising Star Award in 2023. So we are talking to a very budding embryologist who has so many laurels in her cap, right, at this start of her career. She is a PG Diploma Clinical Embryology from Charudutt Academy of Research and Education under Professor Natarajan and won the gold medal for university first rank. She completed her MBBS MD Physiology and won the Best Pedagogy Award during the post-graduation, doing her PhD in male infertility, and completed her embryo biopsy training at NITA, Agra. And she's a faculty for Indian Council of Obs and Gynae certificate course in reproductive medicine. She is faculty in various workshops, active researcher and a member of the Global Embryology Forum, and a very active ESHRE member and life member of many particular big organizations. And today she would be talking on walking on eggshells. Will ICSI emerge as a new standard for penetrating the zona pellucida, PIEZO-zona pellucida? So over to you, Dr. Lakshmi, for your very interesting talk.
Thank you. Thank you so much for the kind introduction, madam. So good evening, everybody. Today, this journal club topic is going to be on PIEZO-ICSI. Emerging technology in assisted reproductive technique, that is PIEZO-ICSI. In this journal, we are going to talk about walking on eggshells. This is an article published in Fertility Sterility 2024 by Lawrence et al. In this article, they have raised the question whether the PIEZO-ICSI will emerge as a new standard for penetrating the zona pellucida. So moving on to the journal as such, here I'm going to split. This is a review article like journal. Hence, I'm going to split the journal article into 3 sessions. First, basic understanding about PIEZO-ICSI, in what way it is different from conventional ICSI, and then the comparative analysis of PIEZO-ICSI and the conventional ICSI, considering the adoption, whether it can be adopted in our regular practice and what will be the future implications. Coming to the first part, understanding the PIEZO-ICSI, how it started was initially started in 1995 using mouse models. Later on, it developed by moved on to rabbit, equine, and bovine models. All these animal models, they have demonstrated an improved fertilization rate and embryo development rate. They have also compared the clinical pregnancy rate between PIEZO-ICSI and conventional ICSI and found that it was better. Later on, in 1999, it came into human application. There also, in this article, they established an improved fertilization, increased survival rate of the oocytes, low degeneration rate of the oocytes, and also they improved embryo quality. So, with this basis, we are moving on to what is PIEZO-ICSI as such. It is an innovative approach which utilizes a blunt tipped micropipette instead of sharp ICSI pipette, and it uses an instrument to produce a rapid piezo pulses to penetrate the zona pellucida and the oocyte membrane, that is the oolenma, without aspirating the cytoplasm. So who will be benefited from this PIEZO-ICSI as such? In this article, they have stated that the patient at risk of suboptimal fertilization or increased oocyte degeneration, that is, the patients may have advanced maternal age or previously poor outcome with conventional ICSI, can go for PIEZO-ICSI. So coming to the procedure as such, this is an extra points, basic points, which I have added on my own just to understand what is PIEZO-ICSI. You need a piezo expert for this. This is an instrument which delivers the piezo impulses, and it is a compact control unit which can be placed close to the operator. This is additional thing which we can add up to any micromanipulator which we are having in our lab. And addition to this, you have a piezo actuator, which is a specialized instrument which is going to deliver the high frequency, low amplitude mechanical pulses. Here you can see the pipette adjustment, which uses a blunt micropipette, which delivers the mechanical force for drilling the zona. And this is a control panel where you can adjust the intensity, speed, and pulse. In conventional ICSI, as in the discussion, as Charu sir said, it depends on the individual's experience. Young embryologists cannot give a good fertilization as a senior embryologist. For this purpose, they have developed this PIEZO-ICSI. In this, you can adjust the intensity, speed, and pulse, in which you can control the manipulation speed, everything. So this is a video just to show you what is PIEZO-ICSI. Here you can see the blunt pipette used here instead of sharp pipettes. This can be used to immobilize the sperm also. Here they are delivering the piezo impulse and aspirating the sperm inside the piezo micro pipette, which is blunt. Here you can see the pipette entering the oocyte. So while penetrating the zona, the piezo impulse will be delivered at a constant speed and intensity. They are trying to break the oolenma, and you can see the sperm moving closer to the surface, and it is being injected into the oolenma. So here they are claiming that the degeneration rate will be less and the embryo quality is better due to the lesser damage to the oocyte. So coming to the applications of other applications of this piezo impulses, you can do sperm immobilization using this. You can do ICSI with this, and you can do enucleation or nuclear transfer with this, blastomia biopsy. This all the other last four have been established only in animal models, not yet established in human application. And biopsy of equine embryos has already been done using piezo pulses. And RNA and DNA injection into the fertilized oocytes have been done in animal models. So this is about the basic introduction of PIEZO-ICSI. Coming to the comparative analysis of PIEZO-ICSI and the conventional ICSI, here in this review article, they have mentioned 5 references. I have gone into detail as much as possible into the 5 articles mentioned. The first article is just about the mouse model, which they have developed the PIEZO-ICSI first. The second article is published in 2020-24. So this is a randomized control trial, which is the highest, considered as the highest level of evidence. And this used sibling oocytes. That is, a patients who got more than 6 mature oocytes are included in the study. Among the 6 M2 oocytes, they have divided the sibling oocytes for a piezo group and the conventional group. If they got an extra oocyte, they have put in a conventional group. I couldn't get the complete article of this because it is a very recent article. So I went on a little bit about the article. So in this article, they have included 108 participants, and they found that better fertilization rate, that is 71.6% with PIEZO-ICSI, and slightly lower fertilization rate, that is 65.6% in conventional ICSI. Here they have included, compared the oocyte degeneration rate also, which is less with PIEZO-ICSI, and a better embryo quality was also found in PIEZO-ICSI. And again, they have compared the aneuploidy rate and embryo utilization rate and clinical pregnancy rate and live birth rate also. So after single embryo transfer, there is no difference between PIEZO-ICSI and conventional ICSI in terms of aneuploidy rate, embryo utilization rate, and the clinical pregnancy rate and the live birth rate. So this is about that recent RCT. And another retrospective study was published regarding PIEZO-ICSI with 72 patients. Here also they have compared the outcome between PIEZO group and the conventional group. Here they have included patients with at least 5 oocytes in this. Here also they found the little higher fertilization and the lower degeneration rate with PIEZO group. Coming to the another study, which was published in 2019, that is 2019, this included, usually in all the literature evidence, we can find either studies for supporting PIEZO and also against PIEZO. And this is a study like that. In this article, they found no difference in fertilization, survival, and blastocyst development between the two PIEZO and conventional group. Here they have included around 947 oocytes. But when in the same study, when they separated and done a subgroup analysis with patients greater than 35 years and lesser than 35 years, they found that better fertilization and blastocyst development in PIEZO group compared to conventional ICSI. So ultimately, we will be worried about, as in the previous discussion also, we are very much worried about the clinical and the neonatal outcome. So compared, we want to know what is the neonatal outcome when we use PIEZO-ICSI. So this is again a retrospective study which is published, and this used around 1,348 M2 oocytes from 145 patients. And here they have found that better survival rate and better fertilization rate with PIEZO-ICSI, but they found no differences in blastocyst development rate, implantation rate, miscarriage rate, and live birth rate also. And the neonatal outcome was not specifically mentioned. They have just mentioned that congenital anomalies were similar between those two groups, and there is no statistical significant difference between the two groups. So considering the adaptation and future implication, based on this review of literature of those 5 articles itself, we came to know that only the research is very limited in this area and it is an upcoming technique. So based on this, there are certain advantages, that is improved fertilization, lower survival, higher survival rate, lesser degeneration rate, improved embryo quality in certain patient population. Who are the patients which are benefited, who are benefited from the PIEZO-ICSI? We don't know, yet to be established. In certain articles, they have stated that poorer outcome patients in the previous conventional ICSI group. So coming to the safety consideration, here we want to have a operating fluid which is used in that PIEZO pipette, that is fluorinant. Usually fluorocarbon based fluids are used. In the initial stages, they have used mercury for this. So the interaction between the mercury and the PVP, the effect of that was not still studied. Yes, we want to wait for the conclusion. Coming to the limitations, as I said, one safety consideration. Similarly, they claim that when you do PIEZO-ICSI, before doing the PIEZO impulse delivery itself, some of the oocytes can have broken oolemma. That is, the oocyte cytoplasm may get leaked. So some studies say that there are reduced survival rate of these oocytes which have low stretchability of the oolemma. This happens in PIEZO-ICSI also. The same thing happens in conventional ICSI. Hence, we have to take this into mind before practicing PIEZO-ICSI. So coming to the integration into practice of this method, it can be the future of robotic ICSI and automated ICSI, as it can control the intensity and speed of delivery. As in the previous discussion, either we no need of specific training for doing this technique, as the machine controls the speed, everything. Coming to the ethical and practical consideration before adopting this technology, it should be carefully studied. Definitely there is a need for future research in this topic, because we have very, very few studies based for this. to support or for against also. Coming to the limitations, another major limitation is a cost analysis. This adds on to the cost. The manipulator, the injection pipette which I have showed, it costs around 18 to 20 lakhs, which can be added to your routine micromanipulator. So it adds cost to the patient also. So before implementing this technique into our practice, every embryologist should consider cost benefit ratio. For each and every drug, every treatment in medicine field, we will consider this. Hence, for PIEZO-ICSI also, we should consider the cost benefit ratio. Whether the patient really benefits from this newer technique or not, we should analyze and then only we should adapt. So my conclusion based on this topic is, think before adopting any newer technique into your practice. IVF can be done in poor oocyte quality also, even for non-male factor patients. Only for male factor patients with poor oocyte quality, we can think about this and wait for a systematic review or meta-analysis. Till that, we are in an early phase. Thank you so much for giving this opportunity. Thank you, sir.
Yeah, thank you so much, Dr. Lakshmi. Dr. Charu sir, your comments, please, before we start. I mean, it looks very robotic and but very costly, as Lakshmi told us, 15 to 20 lakhs more added to the ICSI. So,
Yeah,
yeah, comments, sir.
see, in my view, see, we can take this example. It is very well explained by Lakshmi in her talk that ultimately anything new when comes, you have to be very cautious in selecting, adopting, and implementing in your setup. Because like right now, what we do is whatever is done in any European country or any other place, and just we read somewhere that, okay, this is benefiting this, and we just try to get it implemented in our system. So it is very important for us first to upgrade our system and then implement that particular protocol in your system. Then only it is benefited. Otherwise, it's not going to help you out. Similarly, this is, I feel, more of traditional policies of the multinational companies. Whenever they come up with some new thing, they come up with some few articles and they will say this will, like we have various examples in India, like Poloscope. Once it is introduced, so many things, so many workshops, so many papers were there on Poloscope, and now it is nowhere in picture. So similarly, I feel this PIEZO-ICSI, it's no doubt, it's a new techniques are always welcome, because ultimately in ICSI, all of us have a major concern of damaging the oocyte. Not only oocyte, the cytoplasm, the genetic material, there are so many factors which is at risk. So yes, if something better comes to help us out in reducing this factor during ICSI, definitely it is welcome. But I fully agree what Aanantha says. We need to have more practical data on it, because worldwide it has been introduced, but I don't know how many centers are really using this technique right now. In India also, it has been, in fact, in ACE conference, one of the ACE conference only, this is launched, this PIEZO-ICSI by this DSS people. But then I don't think many people in India only are using it. So let's wait for some time, and then probably we have better use of this technique in our day-to-day practice. And of course, cost in India is always an important factor. We have to consider it. But now what I feel is that there are bigger institutes doing large number of cycles, number of cases has been increased. So cost, at least somehow they can manage, but still ultimately the outcome matters. If outcome improves, then cost doesn't matter. You can do anything and you can put the instrument and you can do it. But ultimately, if it's not going to improve your results, then I don't think it is worth spending that much of amount. Like we were discussing about this benchtop incubators earlier, that like the center were performing 1 or 2 cases or 4 cases in a month, may not be beneficial for them to have a investment on benchtop incubator, like particularly like embryoscope. But if the center is performing 50 cases, I think absolutely it is feasible for them to have embryoscope, because it is now most of the places, most of the paper, it has proved that it improves the selecting criteria of our embryos and improve the success rate. But then again, cost is very important factor. So I think in this particular case, PIEZO-ICSI, we need more data. We need to wait and see if anything comes better than this.
Yeah, very rightly said, sir. We have to consider the cost benefit and wait further for more studies to come, and whether really it is just a gimmick by these companies promoting it, or whether it really the results do matter. So I
It
think we will.
happens. It happens, madam. Most of the time, it is multinational company which just want to come up with some new product and they just want to have some trials and they will select out few, 1 or 2 centers where they will offer it 50% of the cost, or maybe some scheme that, okay, you use this and you give us data and all. But then practically we need to wait, I suppose. We need to wait for any new technique because each and every egg is equally important for us. We cannot put into risk.
Absolutely. So I think that was some, but at least we should know what new has come
Yeah.
up, and that was I think the motive to put this
I think
topic.
in this I am very clear. Like Shilpa, Aanantha, they are having a very hard future. I know, but because tomorrow we may have an AI sitting in the lab doing ICSI, and there is no need of these people. You know, so anything can
But
happen. So
actually, on this 25th, we are having a discussion on AI in infertility, and this 25th June, next Tuesday. So AI, how it would help in for a embryologist and for a clinician, we would be having a great discussion, a panel discussion, and I invite everybody, whoever has joined us today, to again join for that particular talk and topic. It would be at 8 o'clock on 25th. And we would again find out whether, I mean, how much AI or how much of our intelligence and how much of artificial intelligence we should be using.
But
So these
but
are.
but but you know, madam, in this AI, I asked this one particular question, and I'm still waiting for the answer from the developers of this AI. That if something goes wrong with the use of AI, who is responsible? Is it embryologist or the AI system or the creator or developer of that AI or the clinician? Because abhi to we can always say, oh Shilpa, you have not done this correctly. But
Yeah.
when an AI is performing something, to whom you will tell that this is not done properly? So it's very difficult.
Yes, that is true, sir. Actually, whom to catch then? Whom to blame then?
No, no,
Yeah,
they don't have answer, madam. They don't have answer to this. That who will be responsible if something goes wrong with AI? No answer.
yeah. So we still have many things coming. Very exciting period for all of us. We're very exciting for the new embryologists who are coming up. They have they have to learn so many things. Very. I mean, it is a very thrilling sort of a field now, which is infertility has become, and we are all a witness to all these changes that are coming up. And I think we are watching, we are going through this era of so many developments, which makes us proud, and which makes me feel lucky that at least I was born in this age, so I could witness so many things in the history of infertility and science that way.
Correct.
So
Correct. And
yeah,
more than you, these people are fortunate that they will see this all
more,
new
they'll see
things.
much more than us. Once we are gone, maybe till that time more things will come. So
Yes,
thank you
yes.
so much, Charudutt sir. It was really such a nice and very casual but very important discussion that we provoked. And thank you, Dr. Shilpa and Dr. Aanantha, for your presentations, your time. And thank you all the participants who are here with us today. And thank you, ISAR Haryana. Thank you, National ISAR, for giving us the opportunity.
Madam, lage hath request them to come to ISAR Embryology, Chandigarh.
Ah, yes. ISAR Embryology, Chandigarh. We invite you It is going to be a wonderful conference on 31st of August and 1st of September at Chandigarh. So please start. This is, I think, early bird is still on, and you can all please register. And it is going to be a wonderful embryology ISAR conference. So welcome you all there and see you there. And thank you so much, sir. Thank you. Thank you,
Thank you,
everybody.
madam.
Over to Dr. Deepika. Thank you so much, Deepika and Jackson Paul, for the platform. Over to you.
Thank you very much, ma'am. And before we close, I just wanted to share with everybody that we have recently launched our mysaki.in website, which is a corporate social responsibility of Jackson Pal. Here we are, raising awareness about all the women's health concerns that the lay public can go and check out. This website is having a lot of content which we are now building in. So we have started with menopause actually, but it will have from adolescent, reproductive age and menopause, all the health concerns that are there for the women. And there'll be a lot of stuff that they could read up, the public. So we are in fact raising awareness and started with menopause as of now, a half an hour kind of, webinars of public awareness, especially right now on menopause, but we will be taking up all the other topics which are of interest to the women. Here we'll be providing them with the educational content. We'll have a community engagement where they could, interact with each other and with everybody else, also with our experts and all. And you could also be a part of our, webinars by imparting them the public awareness knowledge that they would like be interested in. Like so also in the IVF segment, there is so much that the women do not know. In fact, the public doesn't know so much, as of course not that high quality which is required by the doctors. But then for the public awareness also, we could start some topics like that. So this is the QR code which can be scanned to log on to mysaki.in. That is the website, and you could explore the website and be a part of our experts also to guide the public. Apart from that, just having a recap of our two of our products. That's the Lycored M for male infertility, which has L-carnitine, N-acetylcysteine, CoQ10, lycopene, zinc, and selenium. So added advantage to win the race, fortified proper Lycored M tablets. Then we have Cystilia M, the myoinositol and dechiroinositol 40:1 ratio, the correct ratio for restoring the reproductive health, and Dynogest 2 mg tablets as Endorec. So thank you very much. We would like you to be a part of this initiative also in our CSR initiative, mysaki.in. Thank you very much. And thank you
Thank
to
you
all
so
the
much.
delegates for joining today.